All right, everyone. Good morning. Settle down, settle down. So today, we're diving into Chapter 12, the cardiovascular system. And look, I want you to forget the textbook diagrams for just a minute. We're not just talking about some organ today. No. We are going to talk about the body's most amazing, most reliable miracle engine. This is the engine that literally defines our very existence.
So, what's our plan for today? What's the agenda? First, we'll look at just how powerful this miracle motor of ours is. Then, we'll become engineers and look at its blueprint. How is the heart actually built? After that, we'll get into the pathology. What happens when this amazing pump breaks down? That will lead us straight into congestive heart failure. And finally, we'll discuss some, well, let's call them factory defects, the holes in the heart that are there from birth. Ready? Cello, let's begin.
Okay, first things first. Before we get into all the complex pathology, let's just take a moment to appreciate this thing. I mean, it's pure awe. This engine, it starts running when we're just an 8-week-old fetus, and it does not stop. Not for a coffee break, not for a nap, not for a single second until our last day on Earth. The amount of work it does is, well, it's just mind-boggling, really.
Look at this number. Just look at it. 7,500 liters. This is how much blood your heart pumps every single day. All right, to put that in perspective, you've all seen those big black Syntex water tanks on the roofs of houses, right? The 1,000-liter ones? Your heart fills more than 7 of those tanks every day. It's absolutely incredible when you think about it.
And it does this work non-stop, relentlessly. We're talking more than 40 million beats every single year. Yeah, just think of any man-made engine, your scooter, your car, even a big generator. They all need servicing, right? They need rest, you have to replace parts. But this biological marvel inside our chests, it just keeps going and going year after year. No scheduled maintenance break, nothing.
So the question is, how is such a machine even possible? How is it built? What's the engineering behind it? So now, let's put on our engineer hats and take a look at the blueprint of the heart. We'll focus on the 4 key components that make this whole amazing thing work.
Okay, so here they are, the 4 pillars of the heart structure. First, you have the myocardium. This is the muscle, the bahubali of the heart, the part that gives the power. Then you have the valves. Think of them as the perfect one-way doors or chokadars, making sure blood flows in only one direction. Third, we have the conduction system. This is the sophisticated internal electrical wiring. And finally, of course, the blood supply. Because the heart is a muscle, and it needs its own fuel supply to keep working, right?
Now, this is a very, very important point. I want everyone to listen carefully. The heart's muscle cells, the cardiac myocytes, they are what we call terminally differentiated. Now, what does this big term mean? In simple language, it means that after birth, the heart's ability to repair itself is almost zero. It's extremely limited. If these cells are damaged, say in a heart attack, they are gone for good, finished. There's no regeneration like you see in the liver or your skin. And this, my friends, is exactly why a myocardial infarction is so devastating.
Okay, now for the electricals. The heart's conduction system it's a masterpiece of timing. It all starts with the SA node, the main pacemaker. It's like the main switch that starts the current. The impulse then goes to the AV node. The AV node is like a gatekeeper, a traffic cop. It holds the signal for just a fraction of a second. Why? To let the atria finish contracting and push blood into the ventricles. Very clever. From there, the signal shoots down the highway. The bundle of His splits into the left and right bundle branches and then spreads through the entire Purkinje network, telling all the ventricle muscle cells to contract together. Boom, a perfectly coordinated beat. It's such an elegant system.
All right, so far we've seen the physiology. We've seen how this incredible machine is designed to work perfectly. But even the best machines can break down. So now we have to shift gears from physiology to pathology. What happens when this pump starts to fail? Let's look at the ways it can break down.
Basically, almost every heart problem you will ever see in your clinical practice can be traced back to one of these 6 things. It's a useful framework. Either the pump itself fails, the contraction is weak, or there's an obstruction to the flow, a blockage. Or the flow is regurgitant, meaning the valves are leaky and blood flows backward. Or the blood flow is shunted, it's taking a wrong turn. Or the conduction system has problems, bad wiring causing arrhythmias. Or finally, the most dramatic one, the heart wall itself can rupture. So these are the 6 main ways things can go wrong.
Now, what happens when the heart is under stress? For example, from chronic high blood pressure. Well, it does what any muscle in your body does when it's overworked. It gets bigger.
just like a weightlifter's bicep. This process is called hypertrophy, and it is the heart's main way of compensating, of adapting to the extra load. But, and this is a big but, in the heart, bigger is not always better, as we're about to see.
Okay, have a look at this. This is a real heart specimen, and this is a classic textbook example of pressure overload hypertrophy. Just look at the wall of the left ventricle here. Can you see how incredibly thick it is? This is not normal. This heart has been fighting against high blood pressure for years and years, and the muscle has just bulked up in response.
So that was the gross picture. Now let's zoom in, way in, to the microscopic level. On the left side, you see normal cardiac muscle cells. See how they're nice and slender? Now look at the right. You see the difference? It's dramatic. These are the hypertrophied cells. They are much wider, much bigger, boxcar nuclei, as we say. They're chunkier. Even the nuclei are enlarged and darker staining. So this change at the cellular level is what causes that thick wall we just saw in the last picture. So this hypertrophy we talked about, it's a compensatory mechanism. But it can't go on forever. It has its limits. Eventually, all of these problems we discussed, the pump failure, the obstruction, the hypertrophy, they all lead down the same road to one common final destination. And that destination is a clinical syndrome we call congestive heart failure, CHF.
Okay, now with CHF, it's crucial to understand the difference between left-sided and right-sided failure. The easiest way to think about it is like a traffic jam. A big one, okay? In left-sided failure, the left ventricle is weak. It can't pump blood out to the body properly. So where does the traffic jam, the backup, happen? Well, it happens just behind the left ventricle. Blood backs up into the lungs. And what does that cause? Coughing, shortness of breath, dyspnea. Now, in right-sided failure, the right ventricle is the problem. So the blood backs up into the rest of the body, the systemic circulation. This is why you see swollen legs, pedal edema, and a congested liver, what we call a nutmeg liver. And remember this, the most common cause of right-sided failure is left-sided failure. One traffic jam causes another.
Okay, let's switch gears completely now. Everything we've talked about so far, hypertension, hypertrophy, these are problems that develop over a person's life. But what about problems that are there right from birth? The factory defects I mentioned earlier. Let's talk about congenital heart disease.
So, one of the most common types of these congenital defects is something called a shunt. What is a shunt? It's simple. It's just an abnormal connection, a hole. Imagine the wall between two rooms in your house has a hole. Things will pass through that shouldn't, right? It's the same idea in the heart. A shunt lets blood take a shortcut that it is absolutely not supposed to take.
Now, shunts basically come in two main flavors, depending on which way the blood flows. You have left to right shunts and right to left shunts. In a left to right shunt, oxygenated blood from the high pressure left side leaks into the low pressure right side. So initially, the patient is not blue. There is no cyanosis. But in a right to left shunt, it's the other way around. Deoxygenated blue blood from the right side bypasses the lungs and goes directly into the systemic circulation. This is much more serious, and it causes cyanosis right away, the blue baby syndrome.
So here are the three most common examples of left-to-right shunts that you need to know. First, an atrial septal defect, or ASD. That's a hole between the two atria. Second, a ventricular septal defect, or VSD, a hole between the two ventricles. And third, a patent ductus arteriosus, or PDA. This is a small vessel connecting the aorta and pulmonary artery that is normal in a fetus, but is supposed to close after birth. If it stays open, it's a PDA. ASD, VSD, PDA. Remember them. Okay, enough with the diagrams. Let's look at the real thing. This is a pathological specimen of a heart with a large ventricular septal defect, a VSD. See that? You can see the clear, abnormal opening right there between the two ventricles. And this one, the VSD, you must remember, it is the single most common form of congenital heart disease. Very important for your exams and for your practice. So, to summarize today's class, we've seen that the heart is a complete marvel of engineering, but it is not invincible. It's both a powerful engine and a very delicate machine. So I'll leave you with a question to think about, not as doctors, but as people. Knowing all of this now, what is one thing you can do, starting today, to protect your own miracle motor? Think about it. Okay, that's all for today. Thank you.
Hello, my dear students, and welcome back. So we're continuing our discussion from Chapter 12, and today we are going on a really fascinating journey, deep inside the heart. We're going to look at all its problems, right from the defects someone is born with, all the way to the issues that crop up later in life. So shall we begin? Let's go.
Okay, so let's start with a bit of a puzzle. Just look at this heart here. Something is very, very wrong, isn't it? The blood is going in all the wrong directions. The entire plumbing system is just a mess. But don't worry. By the end of our class today, you will be able to look at this and tell me exactly what is wrong and why it is so dangerous. I promise you that.
So, this is our plan for today. First, we'll talk about the heart's blueprint problems, what we call shunts. Then, we'll move on to cyanosis and blockages. After that, we'll discuss ischemia. That's the heart's supply problem. And finally, the big one, the anatomy of a heart attack, a very important topic.
Okay, let's jump right in with our first section. We are starting at the very beginning, the problems with the heart's initial design. We are talking about congenital problems, specifically shunts. You can think of a shunt as a situation where the blood, well, it just takes a wrong turn.
First things first, what is a shunt? It's actually very simple. A shunt is just an abnormal connection, a wrong connection, between the chambers or the big vessels, which lets blood flow where it really shouldn't. It's like having a leak, a shortcut that's not supposed to be there.
Now, what's really interesting here is that shunts, they come in two main flavors, you see? Left to right and right to left. And believe me, the direction of this flow changes everything for the patient. In a left to right shunt, oxygenated blood mixes with deoxygenated blood. This causes a volume overload, a pressure overload, but initially, no cyanosis. But in a right to left shunt, it's the other way around. Deoxygenated blood mixes with the oxygenated supply, and this is what leads to cyanosis, the classic blue baby you have all read about.
And look at this picture. This is the most common shunt of all, a ventricular septal defect, or VSD. Basically, a hole between the ventricles. This is a perfect example of a left-to-right shunt. You can see the hole right there. That's what's causing all the mischief. So, the crucial point for you all as future doctors is to know that the size of this leaky wall, it determines the patient's fate. A large defect will cause early right ventricular hypertrophy, big problems. But, and this is amazing, small muscular VSDs, maybe about 50% of them, they can actually close on their own. Spontaneously, the body just fixes it. How incredible is that?
Okay, let's move on to our next section now. We've talked about leaks. Now let's see how this builds towards more complex and often more dangerous conditions. We're talking about blue babies and other plumbing problems. Now this is a classic exam question beta, so listen carefully. Tetralogy of Fallot. You must remember these four cardinal features. 1. A VSD, which we just discussed. 2. Obstruction of the right ventricular outflow. 3. An aorta that is overriding the VSD. And 4. Because of all this, right ventricular hypertrophy. These 4. Commit them to memory. Look here. On the left, you have the diagram showing the 4 defects. Simple. But on the right, that is the real thing. That's what it actually looks like. You can see how thick that right ventricle is. This is what gives us the classic boot-shaped heart on an X-ray. It's a textbook sign.
Okay, another major problem isn't a leak, but a blockage, an obstruction. This is a coarctation of the aorta. Look at the picture. It's like someone has put a tight pinch in the main pipe, the aorta, blocking blood from flowing properly.
Now, clinically, this is so important. Pay attention. The classic finding is hypertension in the upper extremities, high BP in the arms, and weak pulses and low BP in the lower extremities. If you see this in a patient, you must think of coarctation. The body tries to compensate, of course, by making these collateral circulations, which can even cause something called rib notching that you can see on an X-ray. Right, so we've covered the birth defects. Now let's look at what can go wrong later in life. We're moving on to the heart zone blood supply when the heart zone fuel line gets clogged.
And the main villain in our story of ischemic heart disease, the culprit in more than 90% of cases is, you guessed it, atherosclerosis.
70%. Please remember this magic number. A blockage of more than 70% is what we call a critical stenosis. This is the point where patients start getting symptoms, like angina, especially when they exert themselves.
So this leads us to a very critical question. How does a stable blockage suddenly turn into a life-threatening emergency? What happens?
The answer is something called an acute plaque change. What happens is the stable plaque, it suddenly ruptures. It breaks. And this triggers a rapid formation of a blood clot, a thrombus, which then blocks the artery completely. It's a sudden, catastrophic event.
And this brings us to our final and very, very important section, the myocardial infarction, or simply a heart attack. We are going to look at the timeline. What happens to the heart after the attack?
You know, the heart's response to an MI follows a very predictable timeline. In the first 12 to 24 hours, you start to see some dark mottling. Then, from day 1 to 3, you get a yellow-tan center and a flood of neutrophils. From day 3 to 7, the area softens as macrophages begin their cleanup work. By 7 to 10 days, you have well-developed granulation tissue. And finally, after about 2 months, you have a dense collagenous scar.
So, what are the first cells to arrive on the scene? The neutrophils. They are the body's infantry, coming in to try and clean up the mess of all this dead heart muscle. This is what it looks like around day 1 to 3.
Next up, the macrophages arrive. Think of them as the cleanup and rebuilding crew. They come and eat up all the dead cells, that's phagocytosis, and you can see new blood vessels forming in this granulation tissue. This is around day 7 to 10.
And this picture illustrates the final outcome beautifully. After 2 months or more, you get this, a dense collagenous scar. This is a permanent patch where the living muscle used to be. The heart does not regenerate, it scars. So what is the take-home message here? What should you remember? Number 1, congenital heart disease is about structural problems. Shunts, meaning wrong flow, or obstructions, meaning no flow. Number 2, ischemic heart disease is a supply crisis. Atherosclerosis leading to ischemia. Number 3, an acute MI is triggered by that plaque rupture and thrombosis. And finally, and most importantly, the heart heals by scarring, not by regeneration.
So I want to leave you with this final thought. The fact that the heart heals by scarring, it's a reminder of its injury, yes, but also of its resilience. Understanding this process, this scarring, is absolutely fundamental to understanding cardiology. Thank you.
Hello, everyone. So a patient has a heart attack. We rush them into the cath lab, we open up the artery, and we save them. The immediate crisis is over, right? But what happens next? The journey for that heart, for that patient, is far from over. Today, we're going to talk about what happens after the attack, a very, very crucial and often dramatic part of the patient's story. Cello, let's get into it. But before we go anywhere, I want to put a question in your mind, a bit of a paradox. What if the very cure, the very thing we do to save the heart, could actually cause its own unique damage? Just keep this idea in your head, because it is the key to understanding everything we're about to cover today. Okay, so our first section. When a heart attack hits, everything becomes a race against the clock. Every single second matters. And this isn't just for the movies, it's a fundamental truth in cardiology, and it's summed up by a very famous line. And here it is. You must burn this into your memory for your entire career. Time is myocardium. What does it mean? It's simple. For every minute a coronary artery is blocked, a piece of the heart muscle, the myocardium, dies. And once it's gone, forever. And the speed at which this happens is it's brutal. Have a look at this graph. Within just 2 minutes of a blockage, that part of the heart stops contracting. It just gives up. And if you wait for just 20 minutes, the cells themselves start to die permanently. Their viability just plummets. This is why we run. This is why we are in such a hurry. So the goal is ekdam simple and urgent. Get that blood flowing again. We call this reperfusion. Now we can do it with clot-busting drugs, that's thrombolysis, or we can go in mechanically with an angioplasty, using a balloon to open the artery. Or in the most serious cases, we can even create a whole new route for the blood with bypass surgery. But here is where we come back to that first question I asked you. Because this heroic act of restoring blood flow, it has a dark side, which brings us to our next section, the rescuer's paradox. On one hand, reperfusion is a lifesaver, no doubt. It saves heart muscle from certain death. But on the other hand, that sudden rush of blood back into that very fragile, very sick tissue can cause a second wave of damage. We call this reperfusion injury. The best analogy is a firefighter saving a house from a fire. They save it, yes, but they use high-pressure hoses that cause a huge amount of water damage in the process. And this slide shows that trade-off perfectly. See the green area? That's all the heart muscle we save by opening the artery. That's our salvage. But the red area? That's the damage caused by the rescue itself. It's incredible, but some studies suggest this reperfusion injury can be responsible for up to half of the final damage. This is one of the biggest challenges in cardiology today. So what's actually going on inside the cell? Well, it's absolute chaos. It's a war zone. The mitochondria get damaged, calcium floods into the cells, forcing them to contract violently. A storm of destructive free radicals is unleashed, and even our own white blood cells can rush in and clog up the tiny blood vessels, causing a no-reflow phenomenon. It's a complete biological mess. And this damage isn't just some theory, okay? You can see it with your own eyes. On the left, this heart has a hemorrhagic infarct. It's literally bloody because the reperfusion has damaged the small vessels. Now look on the right, under the microscope. You can see these very distinct dark lines called contraction bands. That's the muscle fiber locked in a death grip from that massive calcium overload. Okay, so with all this trauma happening inside the patient's chest, how do we track it? How do we know what's really going on? Well, that brings us to our next section. We have to learn how to read the red flags. Now, the most powerful clues are not on an X-ray or even on a standard ECG. The real story, the smoking gun, is in the patient's blood. As those heart cells die, they burst open and they leak all their internal proteins into the bloodstream. And we can measure these biomarkers to see the damage. And the gold standard, the most sensitive and specific biomarker for heart muscle death, is cardiac troponin. You must remember this name, troponin T and troponin I. These are proteins from the muscle machinery itself. If you see high levels of troponins in the blood, you have proof of myocyte death. It is the definitive test for a myocardial infarction. Full stop. Now, here is another little paradox. Look at the graph again. That dotted line shows what happens when we successfully reperfuse the artery. The troponin level actually rises higher and it peaks earlier. Now, as a student, you might think, oh my God, this is bad news. But actually, it's good news. It means we have restored the blood flow and it's rapidly washing out all those troponins from the dead tissue into the bloodstream. It's a clear sign that our intervention was successful. All right, so we've opened the artery, we are watching the biomarkers. But the patient is not out of the woods, not by a long shot. The days and weeks that follow are a time of extremely fragile recovery, which brings us to the many post-MI complications. 75%. Just let that number sink in. 3 out of every 4 patients will have at least one serious complication after their heart attack. It's a very clear reminder that just surviving the event itself is only the beginning of the fight. One of the most feared complications is this: myocardial rupture, a literal tear in the wall of the heart. This happens because the dead muscle becomes very soft and weak, usually around 3 to 7 days after the MI, before a strong scar has had time to form. As you can imagine, this is often catastrophic. A rupture can also happen in the wall between the 2 ventricles, the septum. This creates a hole, what we call a ventricular septal defect. This causes blood to shunt from the high-pressure left side of the heart to the low-pressure right side, and it severely messes up the normal circulation. And then, later on, other problems can show up. This is a ventricular aneurysm. The scar that forms isn't as strong as healthy muscle, and over time it can stretch and bulge out, like a weak spot on a tire. The good news is they don't usually rupture, but they are a huge risk for forming blood clots and can eventually lead to heart failure. And the list of risks just goes on and on. The pump itself can fail, leading to cardiogenic shock. Abnormal heart rhythms, or arrhythmias, are incredibly common, affecting up to 90% of patients. The sac around the heart can get inflamed, a condition called pericarditis, and blood clots can form on the damaged inner wall of the heart. It's a minefield. Finally, let's talk about the surviving heart muscle, because even the tissue that we managed to save, it doesn't just go back to normal immediately. The heart remembers the injury. We have a term for this: stunned myocardium. The muscle cells are alive, we've saved them, but they're in a state of shock. They don't contract properly for hours or even days after the blood flow is back. The good news is, like someone who is stunned after a shock, this tissue can fully recover its function over time. And a related idea is hibernating myocardium. This happens in patients with long-term coronary artery disease. To survive with a low blood supply, the heart muscle goes into a state of hibernation. It just lowers its metabolism and function. It's like it's sleeping to save energy, like a bear in winter. And the fantastic thing is, if we restore the blood flow, this tissue can wake up and start working normally again. So we end where we began, with a question. Our technology is amazing. We can reopen a completely blocked artery in a matter of minutes. But that's just the first step. The real challenge, the one that you all will face in your careers, is this: How do we heal a heart for a lifetime? How do we manage the scar, the remodeling, and all the long-term consequences to give our patients the best possible future? That is the art and science of cardiology.
Welcome, Bacho. Today, we are going to understand what happens when the heart's delicate doors, the valves, come under attack. It's a fascinating and very important topic. So this is our roadmap for today's lecture. We're going to cover these 5 high-yield topics, so please pay close attention. We'll go step by step through each one.
Let's start with this very fundamental question, okay? How can something so small, these little flaps of tissue, cause such big, life-threatening problems in the heart? Let's find out.
All right, first up is a classic case you'll see again and again in your careers: rheumatic heart disease. You can think of it as the delayed revenge of a simple sore throat.
Look at this gross specimen. Bill Gold classic. This is the end result of chronic rheumatic heart disease. You see how the mitral valve has become fibrosed, thickened, and narrowed? It creates this look that we call a fish mouth or buttonhole stenosis. It's a very, very characteristic appearance.
So what is the funda here? What's the mechanism? Well, it's a 4-step story of mistaken identity by our own immune system. It all starts with a group A strep throat infection. Then, our immune system, in trying to fight the bacteria, gets confused. This is called molecular mimicry. It starts attacking our own heart tissue, causing acute inflammation. And over years and years, this leads to chronic fibrosis and that scarring you just saw.
Now, for the pathologist, the microscopic clue is something called the Aschoff body. You must know this term. Think of it as the microscopic battlefield, a little collection of inflammatory cells left behind by this immune attack right inside the heart muscle.
And if we zoom in on these battlefields, you find these very special cells, Anichachko cells. We have a nickname for them, caterpillar cells. And you can see why, nah? Look at that wavy ribbon-like chromatin in the nucleus. It looks just like a caterpillar. This is a must-know for your practical exams, Bacho.
Clinically, how do you diagnose it? You'll use the Jones criteria. You look for these major signs, from painful migrating joints to inflammation of the entire heart, to nodules under the skin, a specific rash, and even these involuntary movements we call Sydenham chorea. Okay, let's move to our next big topic. Now, the attack isn't from within our own immune system. Here, it's an outright invasion by microbes, by bacteria.
This is a brilliant diagram because it shows the 4 types of vegetations we'll discuss. Now just focus on the one for infective endocarditis. Notice the size and location. They are big, they are bulky, and they are incredibly destructive. Very different from the others.
Right. Now, infective endocarditis has 2 main personalities. There is the fast and furious acute IE, and then there's the slow and sneaky subacute IE. Acute is caused by a really nasty, virulent bug like Staph aureus, and it can attack a perfectly normal, healthy valve. Subacute is usually a less powerful bug, like Strep viridans, that needs an already damaged valve to get a foothold. This is a very, very important distinction.
Just look at the sheer destruction here. This is not like the small little bumps, the verrucae, we saw in rheumatic heart disease. No, these are large, crumbly, friable masses of bacteria and thrombus. And because they're so crumbly, pieces can easily break off and travel to the brain or other organs.
And the danger doesn't stop at the valve. Look at this. The infection can literally eat its way down into the heart muscle, right at the base of the valve, forming what we call a ring abscess. This is very, very dangerous.
So who are the culprits? Who are the bacteria involved? Well, it often depends on the patient's history. Strep viridans is a common one after dental procedures. Staph aureus is a big one, especially in IV drug users because it lives on the skin. And then there are others like the Hace group and enterococci. But staph and strep are the big names you absolutely must remember.
Now for a twist in the story. What if the vegetations on the valves have no bacteria at all? Let's look at 2 important sterile, non-infective conditions.
Okay, have a look here. On the left is something called non-bacterial thrombotic endocarditis, or NBT. Notice how the vegetations are small, kind of neat, and they sit right along the line of closure. On the right, we have a diagram of Libman-Sachs endocarditis, or LSE. This one can be a bit messier, with vegetations on either side of the valve leaflet, even on the bottom surface.
The key point for NBTE is hypercoagulability. Basically, the blood becomes extra sticky. You have to think of patients with advanced cancer. We sometimes even call this merantic endocarditis. or other conditions that make their blood more prone to clotting. These little bland thrombocytes then just stick to the valves.
And for LSC, the buzzword is lupus, systemic lupus erythematosus. In this disease, you have circulating immune complexes, and these complexes can deposit on the heart valves, causing inflammation and these characteristic sterile vegetations.
Okay, so what happens when we replace a bad valve with an artificial one? Well, the problems don't always go away completely, they just change. Let's look at prosthetic valves. This is a classic Viva question, Bacho, so listen carefully. You have two main choices. Mechanical valves are very durable, they can last a lifetime. But, and it's a big but, they can cause blood clots, so the patient needs lifelong anticoagulation medication. The other option is a bioprosthetic or tissue valve. It's less likely to cause clots, but it wears out. It will calcify and degenerate over 10 to 15 years. So you see, it's a trade-off.
And this slide illustrates those failure modes brilliantly. On the left, you see the nightmare scenario for a mechanical valve, a huge thrombus, a blood clot that has completely blocked it. And on the right, you see what happens to a tissue valve over time. It's simply worn out, calcified, and torn.
So let's summarize the key points you absolutely must take away from this class. Let's bring it all together.
This table is your revision gold. It compares the four major vegetations we discussed today. Look at the patterns. RHD and LSC are autoimmune. IE is microbial. NBTE is about sticky blood. And look at the last column. The only one that is really truly destructive is infective endocarditis. If you know this table, you are in a very, very good position.
And I'll leave you with this final thought. We've seen how these delicate valves can fail, from immune attacks, from bugs, from simple wear and tear. The challenge for your generation of doctors and engineers will be to create better, more resilient replacements. That's all for today. Thank you.
Hello everyone and welcome. Now, whenever we talk about the heart, what do we usually think of? Blocked arteries, right? The plumbing issues, or maybe faulty valves, the mechanical problems. But today, we're going much, much deeper. We're going to talk about the intrinsic diseases of the heart muscle itself. So come on, let's get started.
So far, we've spent so much time on ischemic heart disease, on valvular problems, but just for today, I want you to forget all of that. Forget the plumbing, forget the doors of the heart. What happens when the problem is the very wall of the room? I mean the muscle, the myocardium itself, when that is the disease.
And that, my friends, is the central question for today's topic. We are talking about the cardiomyopathies. These are diseases that begin right inside the heart muscle.
Okay, so here's your textbook definition. Cardiomyopathy is basically a group of diseases that affect the myocardium. But the key thing, the thing you absolutely must remember, is that the problem is primary. It's intrinsic to the heart muscle. The muscle isn't sick because of high blood pressure or a blocked artery. No. It is sick all by itself.
And these diseases, they basically fall into three main patterns. First, you have the dilated type. Think of it as a weak, stretched-out pump. Then there's the hypertrophic type, which is like an over-muscled, super stiff pump. And finally, you've got the restrictive type, which is a rigid pump that just can't fill up properly. Don't worry, we're going to go through each one of these in detail.
All right, let's start by comparing the two most common types, shall we? We're going to put the stretched-out heart right up against the overbuilt heart. You'll see they are in many ways complete opposites.
So the most crucial point is this. Listen carefully. In dilated cardiomyopathy, or DCM, the problem is systolic. What does that mean? The muscle is just too weak to contract, too weak to pump. It's like a flabby, worn-out balloon, you know? But with hypertrophic cardiomyopathy, or HCM, the problem is completely different. It's diastolic. The muscle is so thick and stiff that it cannot relax to fill with blood. It's like a bodybuilder who is so muscular he can't even bend his arm. A totally different problem.
Now, have a look at these gross specimens. This makes it crystal clear, Hannah. On the left, you see the DCM heart. Just look at how all four chambers are dilated, completely stretched out. It's just a big, weak, flabby bag. Now shift your eyes to the right, to the HCM heart. Alright, look at that chamber. It's tiny. It's been compressed into this banana-like shape because the septum is so massively hypertrophied. It's a world of difference.
And when we go under the microscope, the story continues. On the left there, in DCM, do you see all that blue stuff with the trichrome stain? That is interstitial fibrosis. Basically, it's scar tissue that's replacing the muscle, making it weak. But now, look to the right. This is the hallmark of HCM. This is what we call myofiber disarray. The muscle cells are just going in every direction, completely haphazard.
There's absolutely no organization. This finding is what we call pathogenomic. It's so specific, it's diagnostic all by itself. You see this? You know it's HCM.
And here is a little special finding for you, a real pearl for your exams. In some genetic forms of DCM, especially those with something called titin mutations, you can see these bizarre hyperchromatic nuclei. They look like little throwing stars, so we have a nickname for them. We call them ninja stars. Ekdam classic. You see this on a slide, you must think of DCM, okay?
All right, so we've seen the weak, stretched-out heart and the over-muscled heart, but guess what? There's a third way the muscle can fail. So now let's have a look at the stiff heart.
This one is called restrictive cardiomyopathy. Here, the main problem is stiffness, or what we call in technical terms, decreased ventricular compliance. Now, what does that mean? It just means the ventricles cannot relax and expand to accept blood. So it's another diastolic problem, you see, a filling problem. And the interesting thing is, the systolic function, the pump itself, can be perfectly normal.
And a very classic cause of this is cardiac amyloidosis. Just look at this slide. Do you see this pink, glassy, amorphous material? This stuff is depositing in the interstitium, right between the cardiac myocytes. It's pushing them apart and encasing them in this rigid scaffold. The heart literally becomes stiff, like a rock.
But wait, on a standard H&E stain, other things can look like this. So how can we be sure? How do we prove it's amyloid? For this, we need a special trick. We're going to use a special stain, and we're going to play with a little bit of physics, so pay close attention to what comes next.
And here it is. This illustrates the point so brilliantly. We stain the tissue with Congo red, and then we look at it under polarized light. And what do you see? This beautiful, glowing apple green birefringence. This unique glow is absolutely pathognomonic for amyloid. It's a definitive, and I must say, a very beautiful diagnosis. Absolutely gorgeous.
Okay, so far, we've discussed problems with the heart muscle's structure, right? It's either too weak, too thick, or too stiff. But what happens when the problem isn't structural at all, but inflammatory? Now we're talking about an inflamed, angry heart.
This condition is called myocarditis. And as you all know, the suffix itis always means inflammation. So here, the myocardium itself is being damaged by an inflammatory infiltrate. Most of the time, this is because of viruses, but it can also be from immune reactions.
Now, what's really interesting here is that the type of inflammatory cell can actually give us a big clue to the cause. Have a look. On the left, we see a dense infiltrate of these small blue cells. These are lymphocytes, and that's classic for a viral myocarditis. But look at the picture on the right. See all those cells with the bright pink granules? Those are eosinophils, and you see that in a hypersensitivity or a drug-related myocarditis. So different cells, different causes.
And believe me, it can get even more dramatic. Look at the left. Do you see these massive, multinucleated cells? These are fused macrophages, and they're forming giant cells. This is giant cell myocarditis, which is a very, very aggressive disease with a poor prognosis. Now look to the right. Look closely inside that muscle fiber. Can you see them? Those little parasites? That's Trypanosoma cruzi. This is Chagas disease. The enemy is literally inside the cell. Okay, finally, let's just step outside the myocardium for a minute. Because sometimes, the trouble isn't in the muscle itself, but in the structures that surround it and interact with it.
So here, we're looking at the pericardium. That's the sac that encloses the heart. And just look at it. It's covered in this thick, yellow-green exudate. This is acute purulent pericarditis. It is full of pus, usually from a bacterial infection. And this thick, inflamed sac can actually constrict the heart and prevent it from filling, a very dangerous condition we call cardiac tamponade.
And what about tumors of the heart? Well, they are very rare, thankfully, but the most common primary tumor in adults is this one, the atrial myxoma. You can see it right here, this large, gelatinous hemorrhagic mass just sitting there in the left atrium.
So what's the danger of this tumor? It's mechanical. You see, it's often on a stalk, so it can swing back and forth with the blood flow. And it can suddenly swing down and completely block the mitral valve opening, acting just like a ball valve. This can cause sudden fainting or even death by acutely obstructing the blood flow right out of the atrium.
So let's bring everything together with this summary. Now listen, this is a very, very important slide, especially for your exams, so please pay attention. For dilated cardiomyopathy, DCM, remember the problem is systolic. It can't pump. It's the flabby balloon.
For hypertrophic, HCM, the problem is diastolic. It can't fill. That's our over-muscled bodybuilder. And for restrictive, it is also a diastolic filling problem, but here it's because the heart has become a stiff box. Understanding these core differences is absolutely crucial.
And to finish up, I want to leave you with a question to think about. We've seen that HCM is almost always genetic, right? And DCM can be genetic up to 50% of the time. So as our ability to do genetic testing becomes easier and cheaper, how is this going to change our field? Just imagine, we will be able to screen entire families, predict who is at risk, and maybe, just maybe, one day prevent these terrible diseases from ever developing? It's something to really think about for the future of cardiology. Thank you all for your attention today.
All right, class, good morning. So we often think of a heart transplant as the final victory, don't we? A medical miracle, problem solved. But I want you to understand something crucial today. The surgery? That's just the first battle. The real war, the one that lasts a lifetime, it begins the second that new heart starts beating in its new home. Today, we're going to dive deep into that second battle. So I'll ask you this question. Is a heart transplant the cure? It's a very tempting idea, but no. The reality is much, much more complex. The transplant is not the end of the story, you see. It is the beginning of a completely new chapter for the patient, a journey that is filled with a whole new set of challenges. So, what's the very first challenge? The most immediate one? Well, it's that the body itself fights back. This is what we call the battle against rejection. The body has this incredibly powerful defense system, but sometimes that system can be a little too aggressive for its own good. I want you to think of the immune system as a very, very strict security guard, a chowkidar. It has a list of approved guests, the body's own cells. Now, when this new heart arrives, it's not on the list. The security guard looks at it, says, "I don't recognize you." And what does it do? It attacks. This is rejection. So to treat it, we have to give the patient immunosuppressant drugs. We're basically telling the security guard, "Hey, calm down, Shan To Zhao. This new heart is a friend." Okay, so managing that immediate rejection is one thing. But there's another enemy, one that is much sneakier, one that emerges over the long term. And this, my friends, is the single biggest challenge for transplant patients. It's a condition we call allograft vasculopathy, a silent enemy. Now, that's a big, complicated term, I know. Let's just break it down. Allograft simply means the transplanted organ, and vasculopathy means a disease of the blood vessels. So it's a disease of the new heart's arteries. Over years, these arteries slowly thicken and get narrow. Imagine a clean new water pipe that slowly gets clogged up with rust and gunk. This is caused by that same immune system just crumbling away at a low level, and it eventually restricts blood flow, leading to ischemic injury, which is damage to the heart muscle because it's not getting enough oxygen. And here is why this is so deeply concerning. Look at these numbers. Within just 5 years of a transplant, half of the patients, 50%, develop significant vasculopathy. And by 10 years, virtually all of them have some signs of it. It's almost inevitable, a ticking clock that we as doctors are constantly monitoring. So why do we call it a silent enemy? This is the critical part. During the transplant surgery, all the nerves connected to the heart are cut. This means the patient's new heart is denervated. They cannot feel the classic warning sign of a heart problem. What is that? Chest pain, angina. So they can be having a silent myocardial infarction, a full-blown heart attack, and have absolutely no warning signs. It is a truly dangerous situation. But here is where medicine is so amazing. When biology fails us, sometimes engineering can provide a solution. And this brings us to a remarkable piece of technology, the ventricular assist device, or VAD. It's basically a mechanical pump that can take over when a transplanted heart begins to fail. Now, a VAD is clever. It can play two very different roles. First, it can be a bridge to transplant. It acts as a temporary pump, keeping the patients alive and strong until a suitable donor heart can be found. But for patients who aren't eligible for another transplant, it can be destination therapy. In this case, you see, the VAD is not a bridge to somewhere else. It is the destination. It provides permanent mechanical support for the rest of the patient's life. Of course, putting a machine inside a human being is not without its risks. We have to be realistic. There's always the potential for the machine itself to fail. The formation of blood clots or a thrombus is a major concern. And the device can become a site for persistent, stubborn infections. These are the risks that doctors must always weigh against the life-saving benefits. So, after the battle against rejection, the long-term threat of vasculopathy, and sometimes the intervention of these incredible technologies, what is the final verdict? How do these patients actually fare in the long run? Let's look at the survival rates. And the immediate success is really quite remarkable. A 90% one-year survival rate. This is fantastic. It shows us that we are incredibly effective at getting patients through that difficult surgery and the critical first year. It's a real testament to the power of this procedure. And what about longer? Even at the 5-year mark, the survival rate is still over 70%. So what does this tell us? It means that despite all of these serious long-term challenges, the overall outlook is still very positive. For most patients, a transplant means many more years of good quality life. These numbers are impressive. Yes, we should be proud of them. But for the patients who fall into that other 10 or 30%, it's not good enough, is it? And this brings us to our final question, the one I want to leave you with today. Can our technology make these outcomes even better? Can we one day solve the problems of rejection and vasculopathy for good? That is the challenge for the next generation of doctors and innovators. That is the challenge for you.